Hello everybody and welcome to the Thursday edition of Video Clips. Only one Video Clips edition this week because of the 4th of July holiday. Hope you had a good one, and I hope all of you adhere to my rule, which is to not eat anything that I wouldn't eat, of course, right? So anyway, couple things. First of all, I'm offering a new course which starts in a couple weeks on inflammatory bowel disease, which is a collection of all the research that I've been doing for the last 17 years on IBD. Covers everything. This is people who have Crohn's and colitis. Covers everything from causation to the drugs that are commonly prescribed to the surgical procedures and the complications and all kinds of things. And then, of course, some things that you can do to make life better for an IBD patient, or if you're the IBD patient, some things that you can do, what the research shows might be helpful in terms of diet and that sort of thing. So that starts in a couple of weeks. We're going to start another group with the Food Over Medicine training coaching program in the fall. And by the way, the deadline is tomorrow, but if you sign up for either one of these things, I've got another course I'm going to teach in September, which is based on my new book, Diet Fiction, which is based on our new film, Diet Fiction, which will be coming out shortly. And you might even want to inquire about having a screening and have either me or the producer or both of us spend some time with your group via Skype or Zoom or something of that nature. So stay tuned for details. We have a distributor who bought the film, and so both film and book coming out soon, and you can take the course for free if you sign up for IBD or Food Over Medicine by tomorrow. Okay, so now let's get to topics. The first one is belly fat. You might wonder why I picked that as a topic. Well, the health risks of being overweight or obese are well known, but what's not getting as much attention as I think it should is where weight and fat is carried can sometimes make an even bigger difference than how much fat you're carrying overall. People who have more abdominal fat, regardless of whether or not they're overweight or obese, have a higher risk of conditions like heart disease, cancer, metabolic syndrome, type 2 diabetes, and dementia. And so for this to be a factor, you don't even have to have a weight problem. And many people, as they age, develop more abdominal fat. Men tend to gain more abdominal fat until menopause, and then women see a shift of their fat. It starts to move around a bit and settle more in the abdominal area. Many people don't even gain weight, they just gain abdominal fat, and this increases the risk of disease significantly. The reason for it, we even have a mechanism of action now, is that visceral fat in the abdominal area is much more metabolically active than subcutaneous fat distributed throughout the rest of the body. Now, just some studies that I'll cite, and there are lots of them. In other words, I could probably do a whole 4-week course just on this topic. That's how much information there is. But a study of almost 500,000 women showed that within every single BMI category, including normal at under 25, the risk of coronary artery disease increased as waist circumference increased. Every additional 2 inches in the waist increased the risk of heart disease by 10%. And the most important thing probably about this to understand is that you can be normal weight. In other words, the scale doesn't have to move, but the shifting of the fat or the accumulation of fat in the abdominal area increases the risk. Higher waist measurement increases the risk of cancer as well. And one of the reasons for this, again, understanding the mechanism of action, is visceral fat secretes more growth factors, inflammatory cytokines, and adipokines, which increase the risk. Chronic inflammation in particular is a risk factor, promoting more rapid cell proliferation and angiogenesis. Angiogenesis is when tumors begin to build a blood supply of their own, actually forming new blood vessels to bring more nutrients and oxygen and that sort of thing to the site. A Korean study showed that the risk of colorectal cancer was almost tripled in postmenopausal women who accumulated more abdominal fat. And the researchers concluded that the distribution of fat, again, was more important than overall fatness that was carried all over the rest of the body. A study of women in India showed that central obesity increased the risk of breast cancer in both premenopausal and postmenopausal women, regardless of hormone receptor status. A longitudinal study, including over 6,500 subjects who were followed for an average of 36 years, showed that those with the most abdominal fat were 3 times more likely to develop dementia later in life than those with the least amount. And this effect was independent of other known risk factors for dementia like type 2 diabetes and cardiovascular disease. Asthma risk increases with overall weight gain, but a study of over 88,000 women showed that a larger waist was associated with a larger or bigger increase in asthma, even in women who were normal weight. All extra pounds contribute to an increased risk of disease, so achieving normal weight should be a goal for everyone, but since abdominal fat is a risk factor by itself, you want to avoid developing it and get rid of it if you have it. There are a lot of contributing factors, and I'll tell you what some of them are. One of them is stress. Stress increases the production of cortisol, which in turn increases the deposition of fat throughout the body. Some people secrete more cortisol than others in response to stress, and for many this leads to more abdominal fat, even when they remain lean overall. Consuming too many calories always leads to weight and fat gain, but sugar-sweetened beverages may specifically increase abdominal fat. In one study, overweight and obese people were randomized to consume 25% of calories in glucose or fructose-sweetened beverages for 10 weeks. In both groups, the weight gain was the same, but the subjects that were consuming the fructose-containing beverages showed significantly more abdominal fat accumulation. Alcohol consumption is a risk factor, and consuming more than 3 drinks per day increases abdominal obesity, regardless of diet quality, smoking, and physical activity levels. And by the way, smoking by itself is a risk factor for abdominal fat. Not surprisingly, exercise or lack thereof is a factor both for gaining abdominal fat and losing and keeping it off. A study that randomized people who had lost weight to exercise or no exercise for a year showed that those who did not exercise had a 38% increase in visceral fat, while those who exercised did not regain any noticeable visceral fat. The diet and lifestyle changes that you need to adopt to prevent or get rid of belly fat are the same ones that prevent overall weight gain and conditions like diabetes and cardiovascular disease and cancer. And these are a whole foods plant-based diet, low in fat, exercise, low alcohol intake, lower stress levels. And once again, I think one of the important things to remember from this is that as people age, even if they don't gain overall body fatness and even if the scale doesn't change, as people lose muscle and gain fat, it's a condition called sarcopenia. We even have a name for it. That fat starts to migrate around in the body and it deposits itself in the abdominal area. And so the scale doesn't change. And this can be very deceptive in a doctor's office, for example, where you get weighed every year and everything looks like it's just fine, but it isn't fine because while your weight hasn't changed, everything's shifted around and you still have a much increased risk of many bad things happening like the ones that we've been talking about here. All right, so now on to the next topic. Approximately 91 people die from opioid overdose every single day in the United States. It's a significant public health crisis, and fortunately, there's a lot of conversation about it, but unfortunately, the numbers just aren't changing as yet. We've not seen the reduction in death rate that we're looking for. Part of the reason for lack of progress is because there are so many people involved, and so many players involved. And a few weeks ago, I did a video clip on Purdue Pharma, the maker of OxyContin, that certainly played its role. But another role that we should talk about is the very generous prescribing of opioids following surgery. So the first time this really came to my attention was a few weeks ago. I was watching a news show on this topic, and a physician was sharing his own story. And in this particular case, the doctor's father had gallbladder surgery, and while it's most often not necessary, it is usually not a very invasive procedure these days. In fact, many patients are sent home the same day, and almost all patients are sent home the next day. Well, at discharge, this doctor reports, he goes to pick up his father, and they gave him a 30-day supply of Vicodin. He was flabbergasted. Why not 5 Vicodin pills and instructions to call if he was still in pain after a couple of days? Well, for some people, this generous prescribing of opioid drugs is enough to be the beginning of opioid abuse. I mean, 30 days is a long time to get used to the high and habituated to the drug and want some more of it. Well, a research group recently looked at the prescribing of opioids to over 5,200 surgical patients who had no history of opioid use to see how the drugs were prescribed to them in the 12 months following their procedures. While the number of prescriptions tapered during the 12 months after surgery, they remained very high 9 to 12 months later. I was flabbergasted, to tell you the truth. During the first 3 months after surgery, the patients collectively got 8,226 opioid prescriptions. During the following 3 to 6 months, they collectively received 6,958 prescriptions. During months 6 through 9, 2,167, and during months 9 to 12, we're still at 2,963 prescriptions. Now, what's really interesting is during the first 3 months after surgery, most of those opioid drugs were prescribed by the surgeons who performed the surgery. And then you had about 15% by primary care docs, 2% in the ER, and 1% by people who were in the pain medicine business, that sort of thing. But over time, those percentages shifted quite a bit, with more prescriptions being issued by doctors other than the surgeons who perform the procedures. By months 9 to 12, surgeons only issued 11% of prescriptions, while 53% were written by primary care doctors, 5% by ER docs, and 6% by pain specialists. Now, this is really important since extended use of opioid drugs after surgery has been shown to be one of the leading causes of opioid abuse, addiction, and overdose. So more caution should be used in the initial prescribing of these drugs, and the authors of the study noted that there needs to be a whole lot more coordination between surgeons and other doctors and pain specialists who might be providing follow-up care with these patients. Since we know that surgery increases the risk of addiction in opioid-naive patients. Now, there are a lot of strategies that could be used to address this condition. First of all, discussions with surgical patients should include the potential for addiction and abuse at the time that the drugs are prescribed. And that would be accompanied by prescribing very few drugs, as few as possible, with the idea that, listen, if you're still in pain in a few days, you call and we'll see if you need more drugs. And then with those shorter duration prescriptions at the beginning, there should be evaluation by people who are trained to determine, does this person really need pain medication, or is this somebody who really likes these drugs and would like to have some more of them? There are also many ways that are much more safe to address the situation than opioid drugs. So, for example, NSAIDs and acetaminophen have side effects, but they're not generally addictive drugs, and they should be prescribed more frequently. And then, of course, referrals to acupuncturists and physical therapists and other professionals who can address pain without drugs, that should be a standard part of discharge as well. Now, having said this clearly shows that healthcare professionals need to take more responsibility for this situation. But patients also need to take responsibility, first by learning the difference between excruciating pain that demands relief versus discomfort that passes over time and can be tolerated. I think it's also really important when children and particularly adolescents have surgery and are prescribed drugs afterwards that parents be really diligent to watch for not letting any more drugs be taken than absolutely necessary and looking for signs of addiction, because this is happening in adolescence. I covered the book Dreamland, which was the story of the opioid epidemic in the United States, and one of the primary ways that adolescents became and are becoming addicted to black tar heroin is through prescription drugs issued either for their parents that they steal from the medicine cabinet or for them after a procedure. And of course, this becomes the gateway to illegal drugs like black tar heroin from Mexico, because believe it or not, it's easier and cheaper to get heroin from Mexico than it is to get pain pills to feed your addiction. So if we want to clean this up, we really have to change what's going on in medical settings. We have to educate people about the dangers of these drugs. I have a very good friend who's a politician. And a person who has never been an abuser of drugs. And this individual shall be nameless for purposes that I think you will probably understand. Anyway, after a procedure, he was sent home. This happened years ago with Percocet or Vicodin, I don't remember which drug it was, and took it because the feeling that people have, or the impression they have, is you should always take the drug till the prescription is over. Like you get that instruction when you get an antibiotic, take all the drugs in the pill pack. Well, this individual did that. And at the end of the 30 days prescription, stopped taking the drug because there were no pills and went through withdrawal and said, oh my gosh, I never would have taken the first one if I had thought that this could happen. And of course, this was an individual who had no desire to stay on drugs, highly motivated to get off of them, spent a couple of really uncomfortable weeks dealing with this. But you can see how that might lead some people to say, I got to go get some more drugs. I better go to my family doctor and say I'm still in pain and get some more because I just can't stand this. So anyway, lots of blame to go all around. We talked about Purdue Pharma, the maker of the best-selling drug, OxyContin. Now we're talking about the health professionals discussion, but let's not forget, patients have to take some responsibility too. And part of the informed decision-making process is knowing the potential for these drugs to be devastating to your life and to be very cautious about taking them. All right, that's all for today, and actually all for the week, short week this week. So please pass this on to anybody who you think might enjoy watching it, and I'll be back to you next week with more news.